Is being recorded.
Okay, good morning, our esteemed teachers. Good morning, colleagues. So this morning we'll be started with practice question 2 by Dr. Mohammed. Dr. Mohammed, you have the floor. Please go ahead.
Good morning, my teachers, my senior colleagues and colleagues.
Sorry, please put the slide share, okay? Thank you.
Sorry, is this not national?
Yes, ma.
I thought we are finishing West Africa before we go over to national questions.
Okay, we had some issues with some of the presenters, so that's why we're so that in order not to up.
Abaka,
This meeting is being recorded.
I'm going through the practice question 2 for National Postgraduate Medical College, May 2024. The question reads as follows. There has been a report of rise in CKD among people without diabetes mellitus or systemic hypertension in the community. You are
Dr.
asked to carry out a research topic on...
Mohammed. Dr. Mohammed.
Ma? Yes,
I
ma'am.
don't know if my screen. It's not on slideshow. Your slide just started moving.
Okay.
But is that on slide?
The thing that looks like a cup, a bit, something like that.
Yes, I changed it, but it's not coming up. I don't know why.
Just continue.
Okay, sir. Thank you. So there has been a report of rise in CKD cases among people without diabetes mellitus or systemic hypertension in the community. The candidate was asked to carry out research on the topic. There are two topics there. A, prevalence of CKD in the community. Then B, conventional and non-conventional risk factors of CKD in the community. So the questions that followed were: 1, what research design will you use for the first topic? The second one is, what research design will you use for the second topic? Third, what is the sample frame for the study? 4, what are the benefits of the research to the community? So this question is trying to test the knowledge of the candidate on the choice and even validity of choosing the right methodology, and even the right of tailoring the right methodology to the objective of the study, because it's very important and it's one of the major determinant of fault in research. Secondly, as I was discussing with my supervisor when I saw the question, he said this question is trying to test the knowledge of whether you have done your research right or you have done it wrong. They want to see us with sharing knowledge of research choice and even the methodology. As we know, chapter 3 is one of the most important chapters that is virtually non-compromisable in our dissertation, even our training. So to answer the first question, I will use the next slide to explain the reason why I have gone with some of the answers that I will be sharing with you in the next 10 to 20 seconds. So next slide. So next, answer for question 1. We're going to use a descriptive cross-sectional study design if we're looking at the prevalence of a particular disease in an area. We know that this is an observational study because there's no any intervention the researcher or the clinician is offering in this kind of study. And as we know, prevalence can either be point prevalence study or it can be period prevalence study. For this, we're looking at the prevalence in a particular area. So we're going to choose a point prevalence study to carry out in order to determine the prevalence of CKD in a particular area. And this patient will likely be subjected to questions to ascertain the inclusion and also to put in the exclusive criteria. As we know, data will be taken which involve the social demographic data, some of the clinical presentation, and even some of the laboratory and even radiological parameters that may put this patient into the estimate that we're looking for. Another point to consider is, for the first question, irrespective of either the diabetes or the hypertension status, because those one are established risk factors of CKD, as we all know. But if we're looking at prevalence, we're looking at prevalence of CKD. That is what the first question is trying to establish, the prevalence of CKD in the community. For the research done for 2, we're looking at the risk factors, the conventional and the non-conventional risk factors. So this time around, we're looking at either going for a case control or a cohort study, because we are narrowing ourselves to either a retrospective or a prospective study now. And if we're going for a retrospective study, then we're going to choose case control study. That means there are already established CKD cases, and we're going back to look at the clinical parameters and see whether they have those conventional or non-conventional risk factors. This is very cheap, less time consuming, easy to do, but it's never free of bias, fault, and even uncompleted data. For the cohort study, we're going to look at those conventional and the non-conventional risk factors. We'll follow a patient for a particular period of time based on the natural history of the disease and finding out whether the patient have those risk factors or not. Some of the conventional risk factors are hypertension, diabetes, glomerulonephritis, and the rest. And the non-conventional risk factors are the genetic risk factor, especially problem with collagen, especially type 4, that is found in the kidney, and also some of the environmental exposure, like heavy metals and even heavy water that we find in some part of the country. Cohort study takes longer time. It requires a lot of input. It requires a lot of financial commitment. And there may be a lot of dropout because some patient may die, some patient may not return. So it requires a lot of energy and even resources to complete. For the sample frame, we're going to look at patients that are in the community that satisfy the study criteria. And if you're going to establish study criteria, you have to keep in term with the aims and objectives. Are you carrying the research in pediatrics? Are you carrying the research in pregnant women? Are you carrying the research in adult? Are you carrying the research in individual within particular community? So choosing the sample frame is very important in preventing a lot of low estimate or even a lot of bias. And it also narrows overestimation and even underestimation for the research. The benefit of the research in the community, definitely we know, is to improve understanding and also to identify the major risk factors in the community, and also to look at what are the public health interventions that will be brought in that will help to mitigate the high prevalence that were found, or if there's low prevalence, what are the public health interventions are we going to bring so that the CKD in that community continue to remain at low estimate. It also helps to continue to establish community empowerment so that donor organization, government and non-government organization can continue to fund and aid in mitigating this development of CKD. Common example is some part of the northeastern state and even northwestern state where the risk of CKD is high, and there's an active research by both that is donated, that is being funded by both government and non-government organizations to establish why the rise and why is the high persistent CKD prevalence and even diagnosis in those areas. So all this benefit will help to reduce the disease in the area. As we know, preventive medicine is the key now rather than therapeutic treatment medicine. And this next slide is trying to highlight what I've said. If you're looking at study design, it can either be descriptive or analytical study. And in descriptive study, there's no intervention and there's no advanced statistical input to make a lot of changes or inferences. And that is why carrying out short surveys, online surveys, questionnaire can fall under a descriptive study because you're just describing what you have observed in the community. This has less scientific strength compared to the analytical study, where there may be observation of what is seen or what it was thought to be present, and that is one of our study design, the cohort study, because we're trying to find out, are these risk factors present? Are they statistically significant? Can we relate it to disease? Same thing
Chief,
with
please,
cross-section.
you have 1 minute, please.
Okay. So while the intervention are the clinical intervention, randomized control, quasi-randomized control, trials, and even the quasi-experimental design, then there is also uncontrollable phase 2. Now, this diagram also is trying to explain what we mean by sample frame, and it should not be confused. The sample frame should not be confused from the sample. If you have a larger population, from the larger population, you choose the sample frame. From the sample frame, you choose a sample to carry out your research. Thank you very much.
Oh, thank you so much, Dr. Mohammed, for the beautiful presentation. Thank you so much. So now we'll take comments and questions from the participants first, then our teachers. And then let's keep the thanks coming on the chat box. Let's give the thanks. Thank you for the beautiful presentation. I can't see any hands up yet. Any comments, questions?
Dr. Mamoto's hand is up.
Okay. Chief Momodu, please go ahead.
Thank you so much. Good morning, our teachers. Good morning, presenter. Thank you so much for the presentation. I just have some few additions and possible questions. When you were talking about the sample frame for the study, I so much appreciate the fact that you mentioned the meeting the eligibility criteria. It would have also been nice to even mention some of your sources where you're going to get your sample frame from, even because you're trying to actually get the actual population that will fit into this study. So you could also use those community health records, local population registries. You understand some of the patient data too that can actually help you get a full grasp of that population. Then also for some of the benefits for this research, it's quite important since although you made mention of it, but I would have seen it in the light whereby we would categorize it like public awareness and education in terms of the benefit for that particular community that is having the CKD. Then also policy development too, that can help in terms of healthcare implementation of some of the healthcare provision for them, which ultimately will lead to improve health outcomes. Then also targeted interventions, like following the primary, secondary, and tertiary issues to or levels of care to actually care for this patient. Then please, I just wanted to ask, if I say for the option 1, you said point prevalence study, will I be right too by saying if I do a cross-sectional study design, is it the same thing? Then 2, the conventional and non-conventional risk factors for CKD, you tried mentioning them, that's quite appropriate. So for the sake of exam, I'm mostly opening purpose, I would preferably want to do a retrospective study in terms of I'll do a case control study design. Would that still suffice in the exam? Or rather than mentioning even the cohort control? Thank you. Cohort study, sorry. Thank you.
So thank you very much, sir. Thank you for those beautiful comments and even the very important questions. If I get you right, the first question was, is cross-section study synonymous to point prevalence study?
Yes, sir.
Then second one is the choice of
Just only case control rather than giving two options of both the case control and cohort study, sir.
Okay, good. Thank you. So for the first question, if you say cross-sectional study, it means you are having a single contact, or probably you have taken those sample or your data with a single contact with the patient, or you come across him, take the data, analyze, then you move ahead. And under descriptive cross-sectional study, if you're looking at prevalence, you're looking at prevalence at that point in time, or you're looking at prevalence over a period that you have designed in your research. So they are not synonymous. The point prevalence is still it's one of the arm in determining prevalence under descriptive cross-sectional study. I don't know whether you have gotten my answer.
Okay, you were more or less specific, but you said it's still under an arm. So will it be wrong for me to just say I'm doing a cross-sectional? I'll be using a cross-sectional study design.
Sorry.
Because
Hello. Please, let me just come in here. Hello.
Okay, sir.
Can you hear me?
Sir. Yes, I'm with you,
Yes.
sir.
So the point prevalence is not really a type of study, okay? But you can use cross-sectional study to determine point prevalence.
Yes.
Okay, so the answer to the question is the cross-sectional. And he has already said it. That was his first comment. A descriptive cross-sectional study. That's what he said. Okay, so now you can do it at a particular point in time. It helps you to determine point prevalence. But you can also do it across a period.
Yes, sir.
You understand? You can also do the cross-sectional study across a particular period, but still the cross-sectional study. Okay, so the cross-sectional study is one that just captures the maybe a community at a point in time, at a particular point in time, maybe at a particular point or at a particular period in time. Okay, so it helps you to determine point prevalence, but it can also help you to determine prevalence across a period. Do you understand? So point prevalence is not really the study. It is a cross-sectional study that is a study that helps you to determine point prevalence. I think that should clear that.
Yes, sir. Yes, thank you very much, sir.
Thank you, sir.
So I don't know, Dr. Dalhatu is on the call and he went for the exams. If he can give a clue on what the examiners really want about this.
Okay, that's fine, please.
Okay. Good morning, senior colleagues and colleagues. The examiners actually, during the exam, they were expressionless. In fact, whatever you say, you don't see any impression in them. But actually, just like mentioned, it's better is cross-sectional study. That's the answer. So, but it's good to arm yourself to keep talking and explain most of the things you are saying, because even if you mention, they'll just look at you like that and you won't see anything. I think it's one of the most troublesome station for us. And then for the sampling frame, what they wanted in that question is actually to explain the inclusion and the exclusion criteria for the research. And like you answered the second question, that's question 2. It's better you bring out the two options, either the prospective or retrospective, that's the cohort or the case control study. But by and large, they didn't express anything as regard to what they want for the question. They didn't talk. Thank you.
Hello, sorry, good morning. I just want to add, good morning, our senior colleagues and our colleagues, our teachers. Thank you very much. I don't know, I have a question and I have a contribution. Well, I heard the presenter saying, let me start from the the cross-sectional. Cross-sectional is actually a prevalence study. So Dr. Chief has actually talked about it. Then talking about case control, you can either have a prospective case control, or cohorts, or you can have a retrospective cohort, because he just talked about the retrospective cohort where you look at the outcome and you're looking back at the exposure, which is also a kind of, because it's almost similar to a case control study. So it can be confusing at times. So I really want to also ask, what's the difference between a retrospective cohort and a case control study? Then case control cohort study can also be prospective as well, because there are two types: a retrospective cohort and a prospective cohort. So you have to also specify which particular one you are talking about. Thank you very much.
Dr. Mohammed. Hello, Dr. Mohammed, are you there?
Sorry, Chief Chito can also help us, because it's a bit confusing. I know I've read it too.
Hello, good morning.
Okay, sir. Good morning, sir.
Hello,
Please
good
go
morning.
ahead.
This is Dr. Tito. Yes. So I think we're trying to figure out the difference between a case control study and a retrospective cohort, right? They look kind of similar, don't they? Yes.
Yes.
But I want us to look at it like this. Now, in a case control study, all right, what you're expecting has already happened. Okay. And what you're going to look for is, you're trying to figure out if there's a risk factor that led to this. So you have two groups. You have a case group and you have a control group. Okay? Are you with me? Hello?
Yes, sir, we are with
Can you guys hear me? Okay, good.
Okay.
So in a case control study, what you're looking for has already happened. Like, for instance, you want to see the relationship between lung cancer and smoking. Okay? So you have what you have already, meaning that they already have people that already have the lung cancer, right? And then you go back in time, okay? And you are now looking for those that were exposed to smoking and those that were not exposed to smoking, okay? And you're now trying to figure out if there is a relationship between smoking and developing lung cancer. Are you with me? All right. Now, in a retrospective cohort, now from the name cohort, it just means a group of people that share a similar characteristic. Now, generally in a cohort, you expect that you're following up a group of people to see if something happens, okay? So in a cohort, for instance, if you want to do a cohort study now, and you're looking at, let me look for a good example now. Okay, you're looking at people with diabetes mellitus, and you want to see how many of them develop a certain type of complication, okay? Maybe DM nephropathy or something, okay? And you're supposed to be following people with a certain characteristic. They are similar with that same characteristic, right? Now, most times we look at cohort study from prospective status, meaning that you're starting from the day the one developed DM. And then you have a second group of people that do not have DM, and then you're following up the two sets of people, okay? And then you are looking at, okay, how many of them will develop kidney disease, okay? So you're now trying to link up that and that. It's not a really good example, but I'm just trying to make it as simple as possible, all right? So you're now following them up. Now, in a prospective case, you're starting from the moment, you're starting from the beginning, meaning that you found the people with similar characteristics, you're following them up, you're going forward, okay? Now, in a retrospective cohorts, okay, the people are already developing the thing you're looking for already, okay? What you're doing now is you now want to go back in time. You already have a group of people that are developing that problem, okay? You now want to go back in time and then see if they had DM or they didn't have DM, okay? Now, it's different from a case control study because now they already have the problem, quite all right. You have a large group of people that have the problem and people that don't have the problem. You're now going back in time, okay? Ignoring the fact that, yes, they already have it, but you're doing it like you're starting from scratch, like you're doing a perspective. Although you're already at the point where they developed it, you're going back in time and you're closing your eyes to what they have now to now see if, okay, how were they followed up to this point? And they have to be similar in every way, okay? Unlike when you were doing your case control study, the only similarity they had to do was similar exposure to a particular thing. But in a retrospective cohort, they have to be similar in every way. The population has to be similar in characteristics and everything. And then you're now going to say, okay, this is where we are. The only difference between the retrospective cohort and the prospective cohort is that the moment in time is different. One, you are actually moving with them. The second one, you're already at the end point, but you're going to act like, oh, let's ignore the end point. And you're going to go like you're entering a time machine back in time, and it's going to be like you follow them up to that point. You get? So it's still, it's different from a case control study, even though it kind of looks the same, but you are looking at a different set, you're looking at them from a different angle. You're still following them prospectively, but you're already at the end point already. You're not going to close your eyes to the end point and then see if they get there. Do you understand? It's like you want to, you're going to pick people that the starting point for all of them will be the same, around the same time. Like you want to know how people developed DM nephropathy after they developed DM in 1990. So you're going to pick everybody from 1990 and you're going forward. Do you understand? Okay. But you're going to ignore the fact that you're in the present day. That's all you're going to do. So it's still similar. I hope that was, I hope my explanation was, you were able to get that.
Yes, sir.
Thank you, sir.
I have a picture that I usually use to describe it. I'll look for it and post it on the group so it's easier.
Okay, well, thank you so much, sir, Dr. Chitin. Thank you, Dr. Faye. Thank you, Dr. Momodu, for all the comments. And a lot of thanks to you, Dr. Mohammed on the group, Dr. Deyamo, Dr. Telma, they're saying thanks, Dr. Joy saying thanks, Dr. Florence saying thanks. So thank you so much.
Sorry, someone's hand is up.
Okay.
Sorry, Conte.
Okay, Dr. Conte.
Yes, thank you. I just have a quick question. I understand for case control study, obviously you always have to have a control. My concern is for cohort study. Is it a must that you must always have a control group that you're going to follow, or you can just follow patients that are exposed to the condition that you are interested in?
You don't have to have a control in a cohort study, okay? But you don't have to have a control, whether it's a retrospective or a prospective cohort. But of course, in case control, you must have a control. Okay. So, well, I know Dr. Shitu's explanation, in fact, I started becoming confused at one point. Chief Shitu, you have confused us more. So maybe you should just send us that paper you are talking about. But of course, case control must have controls, but cohorts do not have to have controls. So that's
Can I say something?
that. Okay, please go ahead.
Yes, sir, I have come across something like nested case control, and it can serve, I think, no, nested cohort or nested case control. I think in cohort, you may nest some control inside a cohort. So you blind two axes. I don't. Maybe we will likely read about it. Maybe the next nested cohort, in which you can create case control in a cohort and you continue to observe without actually allowing the participant to understand that there are cohort there, main cohort, and there are controls inside the cohort. It's termed as nested cohort. I think there's another one, nested case control, where you can insert cohort inside the case control that will guide your control in the design.
Okay. Sorry, Dr. Dawat, is it a new hand or the old one?
Yes, it's new hand, please.
Okay.
Sorry. Okay, thank you. It's kind of confusion, but the thing is case control. They develop the disease condition and you have a control that doesn't have the disease condition, and then you ask question as backward. For the retrospective cohort, these are group of individuals that you think they may have the disease or they may not have the disease. And then you look at them and follow them backward, irrespective of whether they develop the disease or they didn't develop the disease. And then you identify the risk factor among those that develop the disease and those things that are there in those that did not develop disease backwardly. That's just the difference between the case control study and retrospective cohort. Then Dr. Mamasani, for the nested case control, is a different entity also. This one is usually sub-categorization. You just pick some people from a particular cohort of individuals. You are following them backwardly. Thank you.
Okay, thank you so much. Okay, so I can't see any other hands and no other comments on the chat box. Okay. Okay, there's a comment on the chat box. Okay, Dr. Mamodu posted case control within a cohort design. A case control study is conducted within a cohort study. Cases of the outcome of interest are identified within the cohort and a specified number of controls are selected from the same cohort. Example, within a cohort of individuals being followed up for heart disease, those who develop the disease are identified as cases and a sample of disease-free individuals from the cohort is selected as controls to study specific risk factors. Okay, thank you so much, sir. Okay, in absence of any other comments, Ma, I don't know, can we go on to the next?
Let's move. Oh, let's move. Yes, please. Thank you.
Okay, thank you. Thank you so much, Ma. Okay, Dr. Rahim, you have the floor now.
Yeah, thank you very much. Hello, please, am I audible?
Yes, I can hear you.
Yeah, thank you very much. My name is Dr. Rahim Yusuf. I'll be taking the practice question 5A. I'm sorry for the initial glitch. Good morning to our teachers, senior colleague and colleague. So the question 5A goes thus. A 23-year-old lady present with fever of 38.9 degrees Celsius, low abdominal pain, and reduction in urine output. She had an induced abortion 2 weeks ago, and her presenting blood pressure was 65/40 millimeters of mercury. The pulse rate was 112 beats per minute, and her extremities were cold. She also had cervical excitation tenderness. On examination, urinalysis done for her showed protein of 1+. Also in the question, we're given a table which shows the electrolyte urea and creatinine of the patient, the hemoglobin, as well as the urine output done in the day 1, day 2, and day 3 of the patient as presented in the table below, as we can see. So the question that follows, 1, what is the likely diagnosis? We have to list 4 differential diagnoses. 6, we are also to list 6 investigations you will do that are relevant to our management and what you will find in the investigation results. Then the 4th question is that what is the critical staging of the patient and how will you manage her? So to answer the first question, what is the likely diagnosis? So based on the scenario given to us, the likely diagnosis is likely to be post-abortal sepsis, based on the fact that the patient had an induced abortion about 2 weeks prior to her current presentation. Now she's coming now with fever and features of systemic inflammatory response syndrome. She has a fever, she was febrile, the pulse rate was, she was also tachycardic too. And there's also a focus of infection, which is likely to be genitourinary from the induced abortion that she had 2 weeks ago. So she has portal sepsis complicated by septic shock because of the blood pressure she presented, which she came in hypotension, as well as acute kidney injury, also based on the parameters presented to us. So for differential diagnosis, the different diagnosis could be it could be toxic shock syndrome. Toxic shock syndrome is actually a toxin-induced acute life-threatening condition that is usually caused by group A streptococcus. It will also be caused by staphylococcus as well. And they usually associated with fever, rash, hypotension, as well as multi-organ dysfunction. That's first. Two, it could also be pelvic inflammatory disease because she has lower abdominal pain as well. And she's also a lady coming with fever. So it could also be a sepsis from PID that the patient had. It could be Wells syndrome. Wells syndrome is actually the severe form of leptospirosis, which is caused by Leptospira species. So this severe form too could present in a similar way of fever. They could also have they could have rash, they could have hypotension, as well as multi-organ dysfunction as well, the severe form, which is known as the Wells syndrome of leptospirosis. Typhoid sepsis could also be a differential as well. She has a lower abdominal pain. In typhoid, usually they have right lower quadrant pain, and they have high-grade fever. In usually the third week, which is usually regarded as a week of complication, they could have AKI, they could have other complications as well. So typhoid sepsis could also be a differential diagnosis in this condition. So cyst investigation, full blood count and differentials is very important. This patient, one in the table given to us, the patient is pale, so we'll be able to confirm the anemia, which could be due to sepsis as a result of hemolysis. The anemia too could also be because of patient is having something that looks like acute kidney injury. There could be background chronic kidney disease too. Patient may also be anemic. Then it's also important the PCV is also important, that we know that patient may eventually require hemodialysis. So we need to know the PCV of this patient. Then the patient also have leukocytosis as well. Just to confirm the sepsis that we are talking about. So the full account, these are the which may be of neutrophilic type. Then urine, as soon as eye vaginal swab and endocervical swab, microscopic culture and sensitivity is also very important as part of septic workup for this patient. Then blood culture has to also be done, which is also very important, also part of the septic workup. Serum procalcitonin is very important. This is actually a acute phase reactant and biomarker for sepsis, and usually it helps us to differentiate the etiology of septic condition, whether we are dealing with bacteria or other etiologic agents. Usually with procalcitonin is usually greater than 2 millimoles per liter, is usually indicated, suggestive of sepsis and of bacterial origin. Then serum lactate, also very important too, is usually also very elevated in septic condition as a result of tissue hypoperfusion due to lactic acidosis. So serum lactate is also one of the markers that is very important, especially for patient coming down with septic shock. The abdominopelvic ultrasound scan is also very important for this patient because number one, patient has an induced abortion 2 weeks ago. One, we need to check the pelvic region, the uterus. The patient may have retained product of conception. Patient may have other pelvic collection within the pelvis. So scan will be able to help us to delineate that. And so if patient is also having acute kidney injury, we also need to check the kidneys. If patient is having background chronic kidney disease, there may be impaired corticomedullary differentiation. Patient may have increased echogenicity of the kidneys. Although we know even in acute kidney injury too, sometimes the parenchymal architecture too may be accentuated. So that's why this ultrasound scan is very important. Then serum uric acid, phosphate, calcium, and albumin is very important for if you are suspecting that patient may have background chronic kidney disease. Uric acid may be elevated, phosphate usually be elevated, calcium may be low, then the albumin is also important. Then serologies for hepatitis B surface antigen, anti-HCV, and traveler screen are also very important because if patient may eventually require hemodialysis, we need to have this serology done for us to be able to dialyze the patient. So these are some of the investigation patient may require. Then what Kidigo staging is the patient in? Patient is actually in Kidigo stage 3. I've actually projected here the Kidigo staging, which is a kidney disease improving global outcome. So, and that actually is divided into stage 1, 2, 3. Stage 1 is when the serum creatinine is 1.5 to 1.9 above the baseline, stage 2, 2 to 2.9 above the baseline, while in stage 3, usually once the baseline creatinine is, the creatinine is more than 3 times baseline, or an absolute serum creatinine greater than 354, or a patient that is in a station of renal replacement therapy. So these are in stage 3. Then as you can see, then also you're looking at the urine output too. For stage 3 is when patient is presenting less than 0.3 mils per, producing less than 0.3 mils per kg per hour for 24 hours, or anuria for 12 hours. Then the table beside it is the table of the question. And then as you can see that on day 1, the serum creatinine was 320. On day 2, the serum creatinine actually rose to 456. So on day 3 was 507. So on day 3, the serum creatinine is already more than 354 based on stage 3 criteria KDIGO staging. Then for the urine output as well, we are given the urine output on day 1, day 2 as 80 and 86, though the urine output was not given on day 3. But however, from this urine output, we know that it's definitely less than 0.3 mils per kg per hour. Because the patient, though is 23-year-old, even if the weight of the patient is like 50 kg and 0.3 times 50, that's for 1 hour times 24, is definitely very higher than what the value given here. So the patient is likely to be in KDIGO stage 3. That's this to stage the acute kidney injury that the patient is having. Then how will you manage this patient? So the management of this patient will actually involves a multidisciplinary approach. Number 1, the gynecologist has to be involved, the nephrologist has to be involved, intensive care physiologist, intensive care physician, the intensivists, they have to also be involved in the management of this patient, because patient has to be managed in ICU, because patient is actually coming in septic shock. Then also, importantly, medical microbiologists too must also be involved in the management of this patient, for the management of the sepsis. Then the management will actually be like in 2 phases. Number 1, we want to manage the sepsis. Now, in managing this sepsis, we're using the protocol for the Surviving Sepsis Campaign 1 hour bundle. This is actually a protocol, a guideline that is actually that is brought out by the European Society for the Intensive Care Medicine in the management of patient coming with sepsis or sepsis or septic shock. Now, in management of sepsis, generally, then usually the bundle has actually been revised over time. Initially, it was 6 hours, later 3 hours, then later the latest one was over 1 hour, and that was actually proposed in 2019, and that actually involves about 5 things. Okay, that needs to be done for patient coming with sepsis. Number 1 is to measure the serum lactate level. When the patient comes, you want to take sample for serum lactate, you want to take sample for blood culture prior to antibiotics administration. The third thing is the administration of empiric broad spectrum antibiotics. That's after sample has been taken. Then to begin of rapid fluid resuscitation with crystalloids at 30 ml per kg for hypotension. Or if the serum lactate is more than or greater than or equal to 4 millimoles per liter, you also want to give this fluid to usually at that rate of 30 ml per kg. Then you also want to administer vasoactive agents to maintain mean arterial pressure greater than 65 millimeters of mercury. Now, for the vasoactive agent, the one that actually recommended is norepinephrine, and that is those that remain hypotensive despite the fluid resuscitation at that rate that I mentioned. So these are the parameters that has been internationally recommended when we are dealing with suspecting patient with sepsis or septic shock, and this thing has to be done within the first hour of recognition of sepsis. So when this patient is present, I will want to manage this patient following this guideline. Now, then of course in intensive care unit. Then the second part of the management of this patient is actually to prepare patient for renal replacement therapy. As we know from the table given to us, this patient is likely will likely benefit from hemodialysis, because the serum, one is that patient is in stage 3 KDIGO. Then number 2, this patient is also having the rise in creatinine, daily rise in creatinine is actually more than 100, which is one of the indication for hemodialysis. So I want to prepare this patient for hemodialysis. And in doing so, the serology has been taken, the PCV has been taken. If patient is anemic, then I would like to transfer the patient intra-dialysis. Then also the serology has been done too, to know whether to dialyze the patient using whether it's infectious dialysis or non-infectious dialysis. Then the dialysis will also be done over 2 hours, this being the first dialysis, then subsequently can be over 4 hours. Then so basically that's the management of the patient. Then we continue antibiotics, then to manage Then we can also, if patient is not improving on the initial empiric antibiotics, then it can be changed to another antibiotic based on the sensitivity when the result of the cultures are out. I think basically that's the management plan I have. Thank you for listening. I will try to attach slide on acute kidney injury before sending it to the page. Thank you for listening.
Thank you so much, Dr. Rahim, for the beautiful presentation, beautiful attempt. So I don't, we have questions or comments first from the participants? Okay, I can't see any hands up yet. Okay, so while we're waiting for more comments, please let's keep the thanks coming on the chats. Okay, please let me just ask this question. Please, what is the indication for dialysis? You said you dialyze. You said something about is it 100? I heard you say something about 100. So
okay,
what would be the indication for dialysis?
Okay, thank you very much. Based on the question, we know one of the indication for hemodialysis as part of the traditional one that we know about chemical and clinical criteria. Also, if patient is having features of hypercatabolism to daily rise of creatinine of more than 100, daily rise of urea of more than 10, daily rise of potassium of more than 1. So this patient creatinine on day 1 is 320, on day 2 was 456. That's actually more than 100 rise in the same creatinine. So that's an indication. 2, the urine output as well too. If patient is anuric for anuria alone for over 24 hours, it's also another indication for hemodialysis in this patient too. The day 1 urine output was given as 80, day 2 urine output was given as 86. This is actually still anuric, at least less than 100 mils in 24 hours. So it's also another indication for hemodialysis in this patient. So I think the patient will actually benefit from renal replacement therapy, yes.
Okay, thank you so much. So we have comments on the chat. Thank you so much, Dr. Tarebizin. Thank you so much for your presentation. Dr. Lalekon, thank you for the lucid presentation. And then Dr. Felix says, should there be a failed attempt at resuscitation before the diagnosis of septic shock is entertained? Okay, so that's a question to you. Please, do you understand the question, Dr.
Yes, I understand. Yes. Thank you. Thank you for that question. And that's why using the 1 hour bundle that I mentioned, the initial thing is actually to administer, the initial thing is fluid administration at 30 ml per kg using crystalloid. Now, for patients that now remain hypotensive, despite the fluid resuscitation, that is the recommended 30 ml per kg. Usually, you don't want to go beyond 2 liters, no matter the kilograms body weight of that patient. So once patient has failed that resuscitation, once the mean arterial pressure has not improved, then patient will now benefit on vasoactive agent, vasopressors. So patient has to be on vasopressors. And that's why I mentioned earlier too, the management must be in ICU. So patient will be on vasopressor while we continue other management. Patient will be on that, we'll continue the antibiotics. And then if once there's indication for hemodialysis, patient will also be dialyzed in ICU. If the BP is not appreciating, electrolyte is going up, then we can use other forms of renal replacement therapy, like hemodiafiltration can be used, SLED can also be used to slow low efficiency dialysis. All these forms of dialysis can actually be done in patient with hypertension. And getting so patient will be on vasoactive agent. So that's the answer to that question. I don't know whether that is taken.
Okay, thank you so much.
Dr. Kele, Momodu's hand have been up for some time now.
Okay, Chief Momodu, please go ahead. Sorry, please go ahead.
Okay, thank you so much for the presentation. Thank you so much. I really appreciate it. I just have some concerns about your diagnosis, first of all. I don't know. I know it's also appropriate to put that post-abortal sepsis, but there's a very serious emergency here. I don't know if we would have coined it into more or less the septic shock now precipitated by this likely post-abortal sepsis complicated by AKI. I don't know, because it looks like he's downplaying most of this. This patient is obviously in shock. I don't know if we can gradually tweak that diagnosis to that a bit, so as to potentiate this hypotension, the cold clammy extremities, everything, the septic shock in itself, in entirety. Then for the patient, you made mention, is it possible this patient has cervical shock syndrome? Some of the patients who has had post-orbital sepsis with remnant, how do I be now, product of conception too, they can have a form of vasovagal syncope, although they didn't give us bradycardia here, but most times they can have, from that retained product of conception, they can have what we call cervical shock syndrome. They will have present with all of this, and immediate management with atropine is very important. Then for the, what do you call it now? Part of the supportive care for this patient, I was thinking if you would explain how you would do that, because you just made mention of you correct if there's anemia, prepared for blood. Well, what other supportive care can this patient get, please, in this setting? Thank you.
Okay, thank you. For the first comment, you actually, well, I think the diagnosis I made, you say what is the likely diagnosis? I say post-orbital sepsis complicated by septic shock and acute kidney injury. So I just feel it's semantics, whether you put it, because we know that for septic shock too, there must be focus of the infection, which is actually to be from the post-orbital sepsis, or is also maybe to us to transpose or juxtapose the diagnosis, because the diagnosis I made still encompasses what you mentioned too. So I don't know how you want it to be, whether the septic shock should come first, secondary to this, and so that's then you say other supportive care. You mean in terms of the anemia? Hello?
No, the other supportive care, as in as the patient is currently now. Some of the other things, patient has in septic shock.
Okay, because the other supportive care, apart from the fluid resuscitation, that's ensuring hemodynamic stability in the patient, treating the renal impairment, it has to do with their calories too, to maintain the appropriate calorie for the patient. And that's why I don't know which other supportive care you actually talked about. You can put us through, please.
Okay, you were quite expansive on the MDT thing. There are also other cases too that you're supposed to mention from the, if you say you were doing a pelvic ultrasound scan, if the pelvic ultrasound scan comes out to be positive, the patient has cervical excitation tenderness. You also have your O&G people who come in. It's not more or less supportive care. Actually, the total approach, they might really need to remove that retained product of conception. It's quite important to also mention that. Also, for your, sorry, the other supportive care, the acid-base balance to correction of some of those electrolytes, you understand, they are actually quite important, particular part that this patient has a septic shock, even before you move up to your renal replacement therapy and the interventions care. Thank you.
Thank you very much. That's actually an omission. Sorry, because the patient actually has hyperkalemia. Thank you very much for that contribution, please. It's actually an omission too. That has to be also, that must be corrected even before the renal replacement therapy. Yes, thank you.
Thank you so much, Dr. Mahmoud, for that excellent observation. Maybe you add it to the slide too before you send it. Okay, so there are more comments on the chat. Dr. Rita is saying, please, there, please, for steroids in this patient. Dr. Adeyemo is saying, thank you for the presentation. We can also use the SEP6 approach. So in addition to the earlier stated, 1 hourly urine output monitoring should be done. So you take 3 blood culture, serum, lactate, and full blood count, and then give 3 oxygen, IV fluid. Okay, that's you take 3 samples, blood culture, serum, lactate, and full blood count.
That's
and then
right.
you give oxygen, IV fluid, and antibiotics, and add ABG as part of your investigation. So he's just trying to like put it.
Hello, class rep.
Give a mnemonic. Hello, sir.
That's okay.
Sir. Hello, sir. Go ahead. I can hear you. Hello.
Hello.
Can you, Dr. Ryan? Can you hear me? Hello, can you hear me? Uh-oh, it's like they're not hearing. Can you hear me
We
now?
can hear you. We can hear you.
Hello.
We
Okay,
can
Dr.
hear you.
I can hear you. Go ahead. Did you hear the questions on the chat? Did you get the questions on the chat? Hello, Dr. Rahim. Is it my network or his own network?
We can hear you, ma.
So I think it's his own network that's
Just
bad.
continue. I think the problem is from his end.
Hello.
Maybe it's his network. I think we can go on.
Okay. Okay, so thank you for the presentation. Please, is the infection suspected or confirmed? Okay, so I think you have to do the culture. When you take sample for the culture, you confirm that. But from the clinical presentation, the
Hello?
patient seems to obviously have an infection.
Oh, God.
Okay, Dr. Yusuf, we can hear you now. Please go ahead. Oh, it's his network. Okay, I don't know. I don't know if we have some comments from our teachers. His network is bad.
Okay. It was a wonderful attempt. But what our advice is, in exam, just always try to be simple and
Hello.
always. Dr. Yusuf, we can hear you. Can you hear us?
Oh, God.
Are you sure you won't log out and come back in? Chief Remigus,
No, go ahead when you're through out.
Yes, so in exam, please, that's not the time to start coining things beautifully. Go straight to the point, no time. So this patient, they created a septic scenario. So they don't need talking about hypotension. We all know that. They don't need portraying hypotension because the AKI is also very important in this patient. We all know sepsis can give you hypotension and can also give you AKI, and it will give you DIC and more complications, multiple organ failures. So we can't start listening to him. So why not say AKI secondary to sepsis? So I think sepsis is the main focus here. This is the background. This is what is causing all of this. It's best to talk about the sepsis, the post-abortal sepsis, complicated by this, all of them. So I think just as the presenter did, it was really beautiful. Just for those going for the exam, case question is this. A similar question is coined in the exam, please. Let's just go for the meat of the matter, just like somebody that have DKA complicated by this. You won't say patient has hyperkalemia from DKA. DKA is the cocoa of the matter. So I believe I'm understood already. Chief Remigus, sir.
All right, thank you. So I just wanted to first of all commend the presenter. I actually did very well. Okay, Okay, and the contributions have been on point too. There were a few things I noted. For example, when it was giving reasons for taking PID, you forgot one very important one. That's cervical excitation tenderness. As I was mentioning, he didn't put that forward as one of the PID. Then in the management proper, when he was talking about kidney replacement therapy, mind you, these days we are moving away from the indication. First of all, in AKI, we're actually not in a hurry to start kidney replacement therapy because we know that some of the poor prognostic factors is actually commencement of kidney replacement therapy. But the truth is that it's not just because of that, it's actually because of the severity of the AKI. So people that need kidney replacement therapy and you do not commence also have poor prognosis. Okay, so but by and large, you have to, most of the time, it's usually depends on the caregiver or the nephrologist involved, okay, when to, because sometimes many of them actually do well. If you can control the sepsis quickly, then the AKI is likely to resolve, okay? So especially when it has not advanced to mobile. At stage 3, most people like to commence kidney replacement therapy. Now, as Chief Shitu will always say, don't play around with hyperkalemia. All those other measures to correct hyperkalemia, they are just, for example, you want to give, glucose insulin infusion. It just moves the potassium into the cells. Immediately you stop giving, it will come back. So you have not removed it. The other measures like using those iron exchange stuff, it just takes out the ones when the person eats, you just reduce the absorption from the gut. But this one, you're talking about something that's already in the blood, okay? Or is it loop diuretics you want to be using? So dialyze, potassium, hyperkalemia is one of the reasons that you want to quickly consider dialysis in patients. So please don't play around. We know hyperkalemia is the cocoa. All this, your urea and creatinine, in on themselves, most nephrologists know that they are not really, really toxic. Somebody can have creatinine of 2,000 and be walking around, no problem. But if somebody has potassium of 7, the person is in big trouble. Okay, so that's the cocoa of the matter, especially that potassium. That's why you want to quickly dialyze this patient. Now, your choices of dialysis actually a bit what the things I actually want to talk about. The modalities, you forgot about peritoneal dialysis completely. Now, someone that is hemodynamically unstable, or maybe I didn't hear, but I didn't hear you talk about peritoneal dialysis. You don't want to do normal hemodialysis or intermittent hemodialysis. Okay, so the modality of choice if you want to do hemodialysis is continuous kidney replacement therapy, formerly known as continuous renal replacement therapy. Even though I heard later on when you started talking about hemodiafiltration and the rest of them. Okay, so but continuous kidney replacement therapy is the modality of choice for people. Some of these patients are already in shock. Okay, so that's the modality of choice. But peritoneal dialysis is also good for them, especially when that one is not available. So please never forget peritoneal dialysis. Okay, so by and large, it's been a beautiful presentation. Thank you.
Okay, Dr. Fatima and so Dr. Chitu right too. So let's hear from Dr. Fatima and then Chief Chitu. Let me see.
Yeah, well done for the excellent presentation, Dr. Yusuf. Part of the modalities of treatment is psychosocial support. This patient needs psychosocial support because she may be disturbed losing her baby. That is very important, especially for those going for national exams. Then I want to also draw the attention of all people going for exam. This question is exactly one of the questions in one of the past questions in national exams. So don't think when we are answering national is not relevant for West Africa, or when we are answering West Africa, no, I'm going for national. That is not the question. No, please just pay attention to whatever we discuss. Everything is relevant. You see how national question is now what is exactly asked in West Africa. But the way they painted the question in national, they were concentrating on the multidisciplinary approach. That was what they concentrated on. So all these other specialties that need to come in managing the patient are very important. Thank you.
Thank you, Dr. Fatima. Chief Chitu, sir.
Sorry, I hope he remembered the
said
MVA for the patient.
I didn't get that, sir.
I hope he remembered MVA for management of the
yes.
patient.
Yes. Now, the Dr. Christabel, please. I don't know if you can off mic for me to say what I want.
Let me pause the recording, okay?
Yeah.